ACHE, State of Healthcare, Industry Leaders' Perspectives, Cost and Quality Transparency, Preston Smith, Dr. Deep Shah, Dr. Tom Price, and Mary Martin.
Welcome everybody to the afternoon session on the little topic, the state of healthcare, quality and cost transparency. We've got a great panel, and this is the one session for which ACHE members can receive face-to-face credit. There is a sign-in sheet out by the exit, so if you don't mind, if you're here and a member of ACHE, the American College of Healthcare Executives, or the Georgia Association of Healthcare Executives, please do sign in after the session and receive credit. ACHE is a great organization. I'm a fellow in the organization and highly recommend it. And they have their very first meeting coming up, I believe in October in Jasper for the North Georgia region. So that'll be a great meeting. Welcome everybody. This is gonna be a great panel. I would like to start us out with brief introductions. And so if you don't mind, Dr. Shah, you can lead off.
Mics are on. Thank you for having us, Preston. My name is Dr. Deep Shah. I'm a primary care physician internist in Gwinnett County, and I help lead Gwinnett Clinic, which is, I believe, one of the largest independent multi-specialty physician groups left in the state of Georgia. So I run that practice, and I also have my own primary care panel. I see patients full-time. And in addition to that, I'm a father of 3 little boys. So we're living a busy life, but very grateful to be here and on this distinguished panel. Thank you for having me.
Hi, I'm Mary Martin. I'm the hospital president of Duke University Hospital and the chief operating officer. Yes, North Carolina is the South, so thank you for having me. I have been at Duke for almost 5 years. Before that was at the University of Michigan Health System, originally from the Detroit area.
Go
and
blue.
I am go green, sorry. We disagree. We've talked about it. It's
Go
fine.
Dogs!
Duke actually has a football team this year. Who knew?
Do I need to separate you two?
But I am also the mother of 2 girls.
Thanks, Preston, and thanks to Health Connect South for putting this on, and thanks to all of you for your affiliation, whatever it may be, with the healthcare services industry. It's incredibly important. I'm Tom Price. I call myself a former. I spent 25 years practicing orthopedic surgery, grew a solo practice into what became Resurgence Orthopedics, 8 years in the Georgia State Senate, 12 plus years in the United States House of Representatives, and then a brief stint at HHS, and I'm honored to be here. Part of our family is new, and that is our first grandbaby. They live up in Nashville, and we're very thrilled.
Thank you, Dr. Price. I'm Preston Smith. I'm the president of Premier Anesthesia. Premier is one of the Jackson Healthcare family of companies. And we contract with hospitals and ambulatory surgery centers around the country to provide anesthesia professional services from soup to nuts. So we have a little visibility into the price and quality transparency issue. And I want to start the conversation just framing that generally. It's been said that the free market is the most honest system in the world. But when we translate it to healthcare, we fundamentally break that system when the buyer, the patient, the consumer, doesn't know exactly what they're buying and, more importantly, how much they cost. And the seller, the provider of the service, often the professional involved, and sometimes the facility also doesn't know what the cost of the service is. So we often find ourselves in obtaining the healthcare and figuring out the costs later. And over time, obviously, there are some ramifications to that. So I want to start just sort of with a high level on this. Transparency is the focus of this panel and its effect on both quality and on cost. So why does transparency matter? Where are we falling short right now, very high level, on transparency? And there's been a lot of talk today over collaboration. Why does transparency and collaboration work hand in hand? And I'll start with Dr. Price.
Thanks. A lot of talk about transparency for a long time, and kind of a goal has been transparency in our entire system. The premise, obviously, is that if things are more transparent, especially in the cost side, if people know what something costs, then they'll make wiser decisions about what it is that they purchase. But you stumbled into one of the challenges that we have in your introduction, and that is saying that the buyer was the patient. So often now in our systems, we don't have a system, we've got multiple systems, the buyer is not the patient. And when the buyer of the services isn't the individual or person that receives the services, then transparency can be total, but it may not make any difference whatsoever. So I think that the goal of transparency is wise, but the transparency has to match with what the system is or what the process is, the logistics of what happens when an individual accesses the system, so that the transparency and that knowledge actually makes a difference.
Yeah, I think the transparency goes beyond price. So if I am getting an MRI, who's reading that MRI? Is it a subspecialist radiologist? Is it a general radiologist? And that's something that our consumers may not be savvy to understand, what level of specialist is reading that study. And so I think as much as we can help to educate our patients, I think that it is very hard for patients to understand the total cost of care or even what their copay is despite all the regulations.
Well, I would venture to say we've probably made little to no progress in transparency since Dr. Price started practicing orthopedic surgery to when I started practicing internal medicine. And the reason is because when you are a physician or any non-physician provider delivering care, you are thinking about a person in front of you. And that is not a list of codes with prices. It is transparency into the disease itself. And a colleague of mine put this very well. When you are diagnosed with a condition, whether it's acute or a chronic one, is it now time for part of that discussion to be, well, what is this going to cost me now and over the course of the next 20 years? So I think if we zoom out and think about it over the course of the patient's life, we start to think of transparency less as a financial imperative and more as a moral imperative to deliver the right care to patients.
What about the confusion that patients have into what exactly the cost is? I had to write this down because it's so complicated, but since we don't have a pharmaceutical representative, I'll pick on them for a moment. A patient who buys a drug at a retail pharmacy, before that drug is priced for the patient, goes through a series, 6 steps, I think, before it's actually priced for the patient. The manufacturer sets the wholesale acquisition cost. The United States is one of the countries where there is no limits, no guidance, no regulations on setting the wholesale acquisition cost. It's done by the manufacturer only. Then the manufacturer goes out to the distributors, and the distributors turn around and the manufacturer gets back an average manufacturer price for that drug. Then the drug goes out to pharmacy benefit managers, contracts between the insurers and the distributors, and sometimes the manufacturers, and then the retailers themselves form group GPOs, and they acquire the drug, sometimes related to the cost set by the PBMs. All of that goes into the pharmacist's cost, and then the pharmacy adds a distribution cost for filling the prescription and charges it to the patient and the insurance company and so forth. A patient has no idea. They cannot possibly know. We who are in healthcare every day have a hard time explaining that process. And that didn't even get into the discounts and the cards and the insurance and so forth and all that. So how can a patient realistically navigate the cost issue for healthcare? And one of the reasons I love this panel is we have orthopedic surgeon, provider, and someone who has public health experience. We have, the president of a very large hospital, acute care hospital with a 1,000-bed tower, quite a complicated job. And we have ambulatory care here with a number of physician clinics, one of the largest in the state of Georgia. So they're great perspectives here. How can a patient realistically navigate the complexities, the Byzantine labyrinth of things that you have to know to even figure out what a drug costs or any other form of health care they're acquiring? And I'll start with maybe Mary.
Yeah, I don't know that they can. I mean, or that they know what the alternatives are. So I'll give a personal example. If you see me walking around, you'll see I walk with a slight limp. I had a deep wound infection that required a 19-day hospital stay and a surgical flap. I was put on an antibiotic called Zavextro, and when I went to fill it, for a 20-day supply, it was $7,000. Now, my insurance covered it, and I had a 10% copay, which is still a heck of a lot of money, But I could call and pick up the phone and talk to the infectious disease doctor that I knew to say, Becky, how critical is it that I take this drug? And she explained, you're going to take it for 20 days, and then we're going to switch you to Doxy. But she has patients in her clinic all the time that need access to this drug, and what are the programs for them to get access to it? So they don't know the alternatives. I'll give you another example. In the hospital, we may have a heart failure patient, and one heart failure patient will get a $5 drug regimen, and the other will get a $500. And when you talk to some of the physicians, and I'll ask, why did you pick that drug versus this drug? And they'll say, well, it was first on the drop-down menu. So I'm like, okay, note to self, put the cheaper drug first on the drop-down menu. No, but it's really that education of when we use which drugs, and a physician doesn't always know what drug their insurance plan will cover. So I don't know that we've cracked that in terms of how a patient would really know, A, is this the drug I absolutely need, and B, how much is it going to cost?
You know, so the interesting thought that I have hearing you is, then why does transparency even matter? Because if our system is so complicated that when you give full visibility to a patient on all of these pricing impacts, so we're fully transparent, how does that actually help the patient?
I think it has to be by patient, that you, and I know we have this at Duke and it is not perfect, that you can call ahead of care or when you're going to get that medication so they can look at your insurance plan, how much you've spent toward your deductible, and give you a reasonable estimate. Because even for surgery, you may price a surgery, but if your surgeon goes in and sees they need to do something different than what they thought based on when they cut you open, I don't know that that price is going to remain the same.
I don't have any stake in the Honda Corporation, but I just bought a minivan from Gwinnett Place Honda. I mentioned my 3 boys. They will not let you purchase the minivan without a financial visit. And I was going to buy it in cash. But they are so concerned that you will leave uncertain about the terms of that bill. Did you know that in Georgia, the hospitals don't even have to send you an itemized bill? And those stays cost a lot more than a minivan. In Texas, legislation just passed, I think, 2 or 3 weeks ago, requiring itemized bill. Now, whether or not that'll be signed remains to be seen. But we have lowered our expectations about transparency so much. We used to say, okay, transparency will slow down healthcare spending. Then we said, it'll just stabilize the rate of growth of spending. But I'm still optimistic, and I think the trick is, how close can you get to the patient level, provide the information, and make impact? I think we have enough data that says patients are not in the mindset to be consumers when they're sick. They don't look at the data. They're too concerned about their health as they should be. So maybe it's at the employer level, at least for employer-sponsored insurance. But there are structural issues that Dr. Price can speak to about what even employer-sponsored plans have access to as they're designing their own self-funded plans. So I think that's a point of action. There are gag clauses that I think federal legislation has tried to address, that at least employers should be able to see how TPAs or third-party administrators run their plans, and how the pharmacy benefit managers administer drugs.
The question about transparency and does it make any difference to the patient, I think it can if the incentives are aligned. The challenge that we have is that oftentimes the incentive for the patient isn't to get the least expensive or the most cost-effective treatment or medication or whatever it might be, because they are insulated oftentimes from the price, from the cost of the service. And unless those incentives are aligned, then you're right, it doesn't make any difference. Why should they care? I have the great honor of being on Medicare. I get to go to the pharmacy and I don't take many medications, but the vast majority of the time, the price that I pay, not counting my premium, which went up when I went on Medicare, but the price that I pay is less than $5. And so, to me, as an individual, and my physician tells me that I need to fill this prescription, I'm not as concerned about it as I otherwise would be if, in fact, I were the absolute purchaser of that service. Now, that it becomes very complex, and also you've got this siloed system. So you've got Medicare and Medicaid, you've got the VA, you've got the Indian Health Service, you've got TRICARE, you've got the ERISA plans, you've got the direct primary care, direct care plans. So, and all of those have different rules, and the price for a specific medication may be different in each one of them. And the price for the patient in each of those systems may be different. So it's no doubt that all of us get confused, and it's no doubt that it doesn't work in a market way, because it really isn't a clean market that would allow the market to affect what's actually occurring, because the incentives are oftentimes rarely aligned.
So I have a theory that as we see the trend increasing for patients to bear more responsibility, high deductible plans, more on the patient responsibility, that patients are going to be more focused on the cost. They'll have to. I think the average or median household income in the United States hovers around $70,000 for the household. So if your household is earning $60,000 to $70,000 and you're being advised to take a medication or have a procedure, I think we're going to see increased focus on cost, not necessarily to the exclusion of quality and other factors, reputation and so forth. But I think patients may become more empowered as consumers, and I think we've seen some of that already. There is some innovation in this area. There's a gentleman by the name of Cody Coonrat who has created an app that publishes various different costs that you can go into. The app is called trybilly.app. It's very interesting. He gathers information about costs and publishes those. CMS, of course, in 2021 began requiring hospitals to publish cost information, and now has escalated the fines that they're issuing to hospitals. The first two they issued were both in Georgia, but they've continued and recently ramped up the fines against hospitals that they say aren't complying with the transparency issue as it relates to cost. So I think we're going to see more focus on that. And yet, when we look at cost, it is difficult to see that Americans pay 250+% more than other countries for drugs. And when you move that to filtering it for just brand is over 300% more. So I think consumers are probably not focused on it when they're in a crisis, but will increasingly have to if they're required to pay a significant amount of their annual household income for health care. And I wonder a little bit about what's going to change. And I think the way I think about patients being empowered is that we have probably never had more information flowing to patients. I was talking with Dr. Price the other evening about the direct advertising to patients for various drugs, which we've all seen. And he told me that it goes beyond drugs now. It's procedures. And if a provider, facility, if a professional doesn't provide the medication requested or do the procedure, then they get a negative review and they have an angry patient who probably calls Mary's office and complains about Duke University Hospital. Where do we think that trend is going? And I'm really, it touches cost and quality, for sure. And we see it in anesthesia. We have patients that come in, they are totally confused about their bill on the backside because they get a bill for anesthesia from the hospital, that's the facility bill, but they have no idea that there's a separate bill for professional services. So they have two bills for anesthesia. They may think they've paid one or one's covered. It's very confusing. But they are coming in now and saying, I want this. I want a Papalito block. I want a regional block. I don't want this anesthesia. And it's putting healthcare providers in a very difficult situation in both cost and quality. So can you comment on that?
So in the primary care setting, we often have patients bring us information, a printout, something they've read, something that a friend has discussed with them. Hey, doc, can you tell me if this is worth it? Full body MRIs is a recent request, and if you follow entertainment news, you may have more insight into that. I just learned about it yesterday.
Kardashians, yeah.
There you go. So, and this is not going to change. It's an increasing trend. But I think Preston made a great point at the beginning during his introduction about the asymmetry of information. The patient doesn't know what it's going to cost, and the doctor doesn't even know what they're charging. But there's a third part of this, and the topic here is quality transparency as well. there is no guarantee that a lower price connotates the same value or quality as a high price. And you'll notice that in the physician delivery side of things and healthcare delivery side, we are very cautious about imposing quality metrics because there are millions of permutations of every single case. So I think there will be more data available. Some places are requiring all payer claims databases, which will help at the employer level and folks who purchase their plans for their employees. But the success will come when there are some reliable quality metrics that are tied to that pricing information. Because you can always find a bottom feeder that's going to charge you less. But the question that you have as a patient is, well, is it as good? And until we have an ability to, I think, clarify how the price relates to the quality in a way that the care delivery community trusts, I'm not sure how much consumers will respond to it.
I also think we don't do a good job of educating consumers on what the cost could be throughout their lifetime. So if you're a newly diagnosed diabetic, have we explained what happens when you progress to insulin or progress to serious vascular disease? And we haven't. And so how do we educate a consumer that, controlling your disease state now likely is a better option and a cost-friendly option than what could happen down the road? And we don't take that tact in healthcare.
The moving greater costs to the patient is clearly on the horizon, especially in the employer-sponsored coverage and other. I believed at one time that was the key, that if you could just, 50 years ago or 150 years ago, I wrote an article called Bringing the Patient Back into the Payment Loop, because at that time, this is literally 40 years ago plus, the out-of-pocket expense for the patient was about 15% to 18% of their total health care bill. That is inched up. I no longer believe that the more that inches up, the more responsible necessarily the patient gets, and I would just cite the fact that most of us know or have heard of, and that is that people have about, or not everybody has $400 of disposable income. So if in fact you bump up the cost to the patient for a procedure or for a medication, I suspect that what's going to happen is that you'll actually decrease the quality of care because you decrease the access that that patient perceives that they have to care. And I know that many of my colleagues, when higher deductibles began to come online, would say that they would talk to a patient or a patient's parents and say, we need to do X, Y, Z, and that the cost for that, the office would say, is going to be about $4,000, and they'd say, well, that's fine, but I can't do that. And if they had a deductible that wasn't going to cover that, or that was within that, then they didn't have access to that care. So I believe everybody needs coverage, and I believe that they need to have a transparency about what that coverage is. And I believe that the way that you can, again, align the incentives is to make it so that the difference of what a patient accesses in terms of both quality and of cost actually inures to the patient's benefit. If we just expect that we're going to put information out there and that folks are going to make the right decision based upon these intangibles, then I don't think that's going to work any better than our current disjointed system. So if you have a high deductible catastrophic plan with a health savings account that covers that and you actually can be rewarded with that and makes a difference to you personally, then I think that kind of thing makes a whole lot of sense. When you get to coverage policies that are paid for by somebody else, be it the government or somebody else, you've got to make certain that the patient has some interest in what something costs or the quality of care that's being provided so that they aren't taken advantage of by individuals that may not have the highest quality care provided.
I think where it has been successful, and I probably shouldn't share this story as a hospital administrator, but when I was growing up, my parents were unionized teachers. If I didn't feel well, they're like, just go to the ED. It's the same price. You wait for the doctor, go to the ED. Now, With my own health insurance plan, if I go to urgent care, it's $30. If I go to the ED, it's $250. You can best bet when my kid has a raging ear infection, we are waiting for urgent care, unless it is, beyond all control. So I do think that there have been pockets of success in driving people to the appropriate level of care.
The gentleman that I talked about that started the Tri-Billy company said, "Cost of healthcare should never be a comorbidity." It's a good quote. And he supposed a hypothetical that I think is kind of interesting, because we only do this in healthcare. In healthcare with employer-sponsored plans, we have a withholding from our paycheck, and that withholding goes to a third party we never really see. They negotiate prices and tell you who's in network and what services you can have according to your plan. And then you find out later, when you look at the cost associated with the care, that it's extraordinary. Now, if you translate that into some other analogy, suppose, for example, that your employer said, "I'm going to withhold money from your paycheck, and I'm going to buy the groceries that you need." And so they withheld money from your paycheck. You didn't really know who they're talking to or what they're buying or how much it cost. And later, when things became transparent, you found out that, with that money they're withholding, they're paying $50 for a gallon of milk and $75 for eggs. I mean, we would go nuts, right? We'd be very angry. So it makes me wonder, as we pull down this curtain and show what a mess the healthcare system is, particularly as it relates to payment and the cost issue, what we think the results will be. And tied to that is the second question, which is, who should police the transparency requirements? Should this be self-governing and allow the market, if you will, to decide, which choice the patient makes? Or does there need to be a society? Does it need to be done by government? If so, at what level? If we all agree that transparency is going to be critical for us to collaborate and for patients to be empowered and so forth, who's going to make sure that everyone does? What do we think should happen?
Seems like Dr. Price might be qualified to answer this one, so we'll let you start.
That's an easy one. I know who ought not do it, and that is people that are so far divorced from the patient that they really can't appreciate the challenges that are going on, and for lack of a better description, they can't really care about that individual patient. So I think the closer you get the decisions about how this works, how our whole system works, the closer you get those decisions to the patient and the patient's family, the people who truly love that individual, then the wiser decisions you'll get. Now that sounds wonderful in the abstract. To make that happen is a huge, huge challenge. I firmly believe that 50 years ago, 60 years ago, when we got away from medical societies being able to actually police our profession, that was a bad thing, because it moved the decisions further away from the patient and the people providing the care. So I think if we can bring those decisions, bring that regulatory framework closer to where the decisions are being made, closer to the community, closer to the patient, closer to the family, then we'll be a leg up on where we seem to be heading, which is to push these decisions further and further away, because I don't think you get the wisest decisions. And I'll talk. The cost for medications is, how are we going to contain drug costs? Well, I mean, Washington does some things well, some things it doesn't do well at all, and what it just put into place, which some people are very excited about, is a negotiation for some drug costs. And so your federal government picked 10 medications and decided that the cost for those medications ought to be somewhere between 40% and 70% of what they usually charged for those medications. And if the manufacturers of each of those 10 medications didn't comply, then they would receive a 95% tax. Well, that doesn't sound, one, like a negotiation. Two, it doesn't sound like it's wise necessarily for the patient. And three, I don't think it'll work. And the consequence of some decisions like that, I believe, to be a decrease in the innovation, decrease in the number of individuals who are trying to solve creatively the challenges that we have in healthcare. And I would respectfully suggest that it would result in many of these bright young minds in here who are thinking about going into healthcare, if you go to the extreme of that, to say, well, heck, I'll go somewhere else and use my talents and treasures. So the closer we can get the long-winded answer, sorry, the closer we can get those decisions by the patient and by the patient's family and the community, then I think the better off we'll be.
One of the things that we've noticed in anesthesia is that there's a trend. More and more patients are in some form of government-sponsored care. Maybe Medicare, Medicaid, TRICARE, Champus VA. It could be a private company administering a Medicaid plan. There are all sorts of variations of it. The Affordable Care Act, of course, opened up a big bucket, but we're seeing a trend of movement from commercial and employer-based plans into some form of government paid plans. And then we see every year there is a proposal regarding reimbursement, which is a concept that patients also do not understand. When you start talking about reimbursement, they don't even know what you're reimbursing who, but from our perspective, it's the professional service. And for the government setting price, it's as it relates to patients who are insured in some way with a payer that's government-based. And every year they recommend a cut. And we see in anesthesia, not an increase, not a stay flat, but every year a cut. And I think what the federal government, is trying to do is contain the costs. But what they're actually doing when they do that is shifting the cost mostly to the hospitals, and then the hospitals have to figure out how to collect the revenue so that they can provide the service and still stay in business, right? So we work with hospitals a lot, and hospitals say, why is the cost of anesthesia going up so much? Well, it's the hospital share of the cost that's going up so much, and that is in part related to the cuts every year. There's a proposal for 5% cut. It's out for public comment. When the final decision is made and the final rule is released, the cut may be 2 to 3%, something in that range. But it's a reduction. And yet, the cost of anesthesia providers is going up because there's a clinical labor shortage. So that means if you know anything about economics, that there is a delta there that has to be covered in some way. And typically, in order to receive the surgeries and provide the surgeries in the community, the hospital has to pay that cost. So there's an increasing subsidy paid by hospitals for the cost of anesthesia. That is directly related to the containment effort that CMS and HHS is trying to do to keep the cost down. So I'm curious, is particularly...
I'm like, let me at it.
I can tell you're getting antsy. You can stand if you want.
No. So I would say that, our labor costs in the past 2 years at my hospital has gone up 13%, and that would include, doctors, nurses, and other allied healthcare staff. It is increasingly difficult when patients are going into, and I'll just use North Carolina as an example, into our managed Medicaid plans. So what we are finding is that the managed Medicaid plan, you'll have a patient, they need to go to a SNF after their hospitalization. That managed Medicaid plan may contract with 1 or 2 nursing homes. Well, guess what? Those 1 or 2 nursing homes are rated as a 1-star. Who in their right mind is sending their family member or their loved one to a 1-star nursing home? So what happens? It's a disputed discharge. They stay in the hospital for 5 to 7 days more while we try and beg anybody that can take this patient. They don't need hospital level of care. Meanwhile, you've got 30 patients in your emergency room. You're backing up your PACU. So it is a huge problem in some of these things that I think, again, were formed with the right intent in mind, but we're not looking at the unintended consequences. And so I think the partnership with the hospitals to say, this is not the appropriate level of care for this patient. We've met with the state a few times, and we're now highlighting some of our extreme cases where we have patients living in the hospital because there is no placement for them. God help you if you need stretcher dialysis, because there is not a place in the state of North Carolina that does that. So I think it's going to continue to have to be a partnership and recognize that what starts with good intent, we need to re-examine, look at the consequences, and come up with different methods.
So before I let you off the hook, I want you to comment on the CMS initiative to issue financial penalties to hospitals that fail to adequately follow their guidelines about cost transparency. And specifically, for students or those that are new to this concept, In 2021, there was a brand new rule, and it required hospitals to disclose several hundred most common procedures and the costs associated with them. And there's some, of course, detailed requirements around it. The early studies showed that 3/4 of hospitals were not fully complying. Most didn't understand what exactly CMS was asking for and how to do that. That's come way up, but starting in about a year ago, starting in summer of 2022, CMS started the financial penalties, and they've increased that, and they've actually restructured them to raise the ceiling to $2 million in penalties they can issue. It's tied to the number of beds and the days of violation. So with someone with a 1,000-bed tower, you probably have a unique perspective on this. What do you think about? We're talking about who should police transparency. CMS is policing their version of this. What's the effect of that, and what will be the effect?
Well, the good news is I think I have the most conservative lawyers that ever existed, so I am certain we are spot on with what we are supposed to be reporting and making public. However, I went and looked at it a couple days ago. Again, it's what's required. I don't know that it's helping patients. A patient's having orthopedic surgery, they don't know what type of screw Dr. Price is going to use in the OR, so again, I'm not quite sure that what they've required is useful. Do I think that we need transparency in an easier format to understand for patients? Absolutely. And I think until we get that holding people accountable because their spreadsheet isn't formatted right, it is not going to do any benefit to the patients.
Well, knowing Dr. Price for over 20 years, I can tell you that if you're in his OR, you're going to get the screw. Now, I don't know what that's going to cost, but maybe he can comment.
They'll get the right one at the right time. Not sure about the price. I would be remiss if I didn't take a little bit of an issue with my dear friends in the hospital community. If you look at that graph that you referred to, which is physician payments being flat or even coming down, and that's over the last 50 years, 40 years. And if you look at everybody else in the system, including my dear friends in the hospital community, their graph goes up. Now, some of that doesn't mean it covers their cost, but in absolute dollars, their payment reimbursement has gone up. Now, that's the good news. The bad news is that it's only going to get worse. And one of the reasons for that is that between 2022 and 2026, the Medicare population is scheduled to increase by 32%. The Medicaid population is scheduled to increase by 14%. And the private pay population in our entire country, which is about 200 million folks, is going to increase by 2.5%. So the cost shifting that is currently occurring will only be exacerbated. And that's why you'll get this huge rush, I think, to the increasing the patient responsibility from a payment standpoint. And that doesn't necessarily help the system at all, as we've alluded to. So,
Dr. Shah.
I should stop you before your dear friends become your former friends of the hospital community, okay? But, so I'm on the ambulatory side of this, and we interact with the hospital systems and the health systems on a daily basis. And so I think an important point is not all hospitals are made equal. And one thing we find in a lot of healthcare policy and legislation is you don't know the effect until it goes into practice. And $2 million is a lot of money, but it's a lot less for a Duke than it is for a critical access hospital in rural North Carolina. And there was some reporting last week on who's getting hit with these fines. Well, it's the one who can't afford the attorneys and the consultants, right? So a $2 million fine, I think, is a nominal fee for many of the systems, but can really be detrimental to those that are already struggling to keep pace with cost in this environment where their reimbursement may be stagnant or declining. My view is that employers, small, medium, and large-size employers, are the best positioned to really leverage transparency and price, at least, because they're still close enough to the delivery, but not the ones receiving the care themselves. Now, there has been some progress for plans themselves that are self-funded plans that employ entities to educate their employees on how to use their services. but those have not scaled. Now, my practice does not deliver direct primary care, but many large Fortune 100 companies are seeing some success in this area. The question is, like everything else in healthcare, how do you scale it? And how do you make it so it doesn't become a burden cost-wise on the employer on the implementation side? So the closer we can get to the exam room for the one who has the information without interfering in direct care, because you don't want to think that your doctor is making a decision based on cost. And no one wants that feeling when they leave the room. They want to know that you're sensitive to it, but that's not the driver of the decision making. So the new generation of physicians that's coming out of training is hearing more and more about this than even I did when I was going through medical school. And so I think that those future physicians, nurse practitioners, physician assistants will have more of a sense of how this is part of care delivery so it doesn't become a comorbidity. The last point I'll make is, we can't ignore consolidation on all sides as a driver of all of this that sort of has allowed us to tolerate the black box of pricing. And that's on all sides, on the insurance side and on the health system side. So what is their incentive to really change? I think it will come from contracting being cut out of contracts. If you don't comply, you're out of the contract. And that is a stronger incentive for them, in my view, than a penalty from the government.
One thing that strikes me is that we're entering into an era in healthcare that is unlike the past, unlike anything we've seen before. I'm a third-generation person in my family involved in healthcare. My grandfather was a doctor. My father was a doctor. Mom was a nurse. They started a hospital in Atlanta. It's a whole different ballgame. And I think that we're seeing a change happening in healthcare, and I'm still focused for the moment on transparency as it relates to cost. But I think we're seeing a shift that touches every piece of this chain, where machine learning and AI are starting to change the game. And I don't think, as much as I love my father and know that he felt medicine was a calling and treating patients was what he was here to do, I think this is a very different environment. And at every piece, I think in revenue cycle, for example, you can use AI and machine learning to see the reasons and the patterns for denials by insurance companies, and you can change how you're submitting claims and maximize the allowable recovery. But that's also true, I think, we're going to find for transparency of cost. I think we're going to see in the next 5 to 10 years organizations that are innovative in releasing information to the public, which is gathered and sorted and produced through AI, and we're going to have a very much more transparent system. Now, whether that's good or bad, or whether it helps or hurts, I don't know, but I think that's the direction we're going to see. My question, we're finishing up the section here on transparency and cost, or as it relates to cost. But farmers say that there's no learning in the second kick of a mule. We've tried an awful lot of things over the last 15 or 20 years. I have to read a lot just to keep up with what's being recommended, the changes, not only in cost, MACRA and MIPS and the requirements of submissions to the feds. And as we increasingly have payment and reimbursement tied to that, it becomes critical because there's a financial penalty that exceeds your margin as a business. So if you get hit with that penalty, in some cases, like the smaller and rural and healthcare organizations and hospitals, it can put you out of business. And we have seen them closing. So I'm curious if you think anything we've done in the last 15 or 20 years has been successful in this area of transparency of cost and cost containment.
Yeah, I think you see some successes. There's an orthopedic practice out in Oklahoma that went completely without insurance. They take no insurance whatsoever, and they post their prices, and their prices are about 40, 50% of what they otherwise would be, and they're as busy as they can be. So when you truly get the problem is that most folks can't access that. I mean, that's not a model that can be duplicated elsewhere. But the principle of being able to align the incentives between patient and the person providing the care is something that could be transferred. So yeah, I think there are great examples out there. I think the sharing ministries that are growing are a way to pool resources and be able to provide essentially coverage for individuals. It's not insurance, but it's a way for people to pool resources to be able to cover themselves and for their family in a way that's been remarkably successful in many, many ways. Again, the principle is that if you truly get things closer to the patient, closer to the individuals affected, and align those incentives, then you can have some successes.
I don't know that we've had success yet, but I feel like we're on the cusp of it. So your point about AI, right now at my hospital alone, we pay the equivalent of 7 full-time doctors to fight insurance claims. Imagine what we could do if I could put those doctors into practice and we had that AI to tell us what claims, or they could do the peer-to-peer reviews. So I absolutely think we're on the cusp. The other thing I think we need to look at is the cost of medical devices and whether those medical devices are having the impact we want. For example, robots in the OR. Everyone, yes. Everybody says it's going to be lower length of stay, better quality, and except for folks being trained in robots and physicians preferring robots, which is fine, there hasn't been necessarily a quality or cost reduction in providing that care. Doesn't help that there's one company you can negotiate with and they make a 23% operating margin. But I think it is going to be imperative that we look at the cost of some of these new technologies and what will truly help us and what will continue to make prices rise.
I think there are some really cautiously optimistic sentiments among the primary care community, at least in the ambulatory space, around direct primary care. You did a good job of laboring through the process of buying a drug. And so eventually, doctors become so fed up, they say, I'm going to call the manufacturer myself. You know what? Maybe I'll just send somebody over to their office and buy direct. And we are starting to see that in different department specialties. Orthopedics may buy supplies, dermatologists may buy equipment. And so eventually it becomes such a mess. You say, I don't need all these middlemen. It may be a convenience to have them, but now it's too expensive to have this convenience. So eventually entrepreneurial physicians and others who really want to focus on care exclusively will cut out middlemen. So I think that's a highlight and something that you see growing across the country. I think right now there's something like 20,000 direct primary care physicians or nurse practitioners and PAs, which is a significant number. So that's a positive. About what Mary was saying, I am less optimistic about what technology will do positively. If you look at Amazon's offering right now, it's a la carte healthcare. And fragmentation of service delivery has demonstrably increased costs at every single level. So if we continue to do what we're doing now and allow big tech and Amazon and Walmart to come into these spaces without a clear care imperative, I'm not sure what that does for the patients. At an earlier panel, somebody mentioned that they got their COVID vaccine at a retail pharmacy. And that just breaks my heart. For a well-educated, insured patient to not receive their vaccine from their primary care doctor is just an indictment of our whole system. Because if people like us, leaders in the field, don't feel connected enough to our primary care home to get what was a very stress-inducing vaccine from your primary care who you want to talk to about it, I think we have questions to answer. And that brings me to a final point about all of this with cost. Trust in our system is at an all-time low. Doctors don't trust the system they operate in. Patients don't trust the system in which they receive care. So transparency is an opportunity to restore trust, which I think is the silver lining in all of this.
Good point. I do want to pivot to quality. We're about halfway through our time. And I have a question specific to our two doctors, although Mary may also have an opinion about this, but it's a perfect segue, Dr. Shah, into the quality discussion. I think it can be said that physicians have been historically the gatekeepers and the central guardians of our healthcare system. Physicians order tests, they admit patients, they perform surgeries and procedures, they prescribe medications. They really have been at the center of our healthcare system. I'm curious, as we think about quality and transparency, if you think that will continue or if that will erode, and what the impact on quality will be. Not necessarily asking you to comment on whether or not it's been a success or failure. It is shifting. Physicians are still the anchor point in our system. What responsibility do physicians have to advance the transparency of quality across the patient base? And to be fair, you may want to say, well, it depends a little bit on whether you're defining quality as a population or service to an individual patient. I think that's a fair point that you may want to comment on, but speak to that from a physician's perspective.
Yeah, this is so incredibly important because all of us want the highest quality of care for everybody that we see and for every patient that is seen in our system. One of the problems with that is that the definition of quality for one patient may be completely different than the definition of quality for another patient for the same diagnosis. So in the orthopedic arena, there are so many examples, but one common one is a hip fracture. And a hip fracture that is sustained by a 30-year-old individual who's a weekend warrior and goes out and breaks their hip, but is otherwise healthy and active and the chief breadwinner for their family. The treatment for that individual is likely completely different than the little old fellow who falls at the age of 88 and breaks his hip and has has all sorts of comorbidities and other challenges from a health standpoint, and whose life is very sedentary. So and what I would do as an orthopedic surgeon is likely a different procedure in each of those individuals. But you try to tell a policymaker or CMS that the same diagnosis code will get different treatment, and both of them will be at the highest level of quality for that particular individual patient. And their head explodes because they just don't understand that. And so from a quality standpoint, physicians' responsibility for individual patients is paramount. I mean, that's what it is that we ought to do. And anybody in the system, that ought to be, from an individual patient standpoint, that ought to be the premier thing that we do. From a population standpoint, that's where I think the governments can get involved and entities can get involved in defining what the bell curve ought to look like in terms of the outcomes that occur. When you do that, you shift the responsibility to the broader medical community, and consequently you shift the responsibility to folks that can actually move that bell curve to the left or to the right, and in not a punitive way. If somebody's just waiting outside my clinic door, waiting to bop me over the head because I didn't ask whether or not the patient had allergies for the 14th time in the last 12 months, or that I didn't get an x-ray for back pain because I know that back pain is 99.9% likely not to have anything radiographically, but you get dinged for it or punished for it or sued for it, then we're not looking really at quality. We're looking at preferences, and so it's a major question, and I hope that what policymakers will do is recognize that quality must be looked at from a population standpoint and not an individual standpoint. We'd save a whole lot of money from a regulatory scheme, but also I think actually move the system in a better direction.
I agree with everything Dr. Price just said, so I'll take it in a little different direction. I was just thinking as we were sitting here and I mentioned Amazon, I wonder if they have star ratings for their people who do the visits. Because this is the world we live in now, where there's reviews of somebody as a patient, and we all pay attention to reviews. And negative reviews hurt doctors much more than positive reviews reaffirm their desire to be in the profession. And as probably everybody in this room knows, most doctors have very big egos,
Stop it. No.
but very thin skin. And so we think a lot about how to give productive feedback. And one thing that was really lost over time, and this is a failure of our profession, is the state, by the state I mean the government, gave us the flexibility to manage ourselves. And for various reasons, we have lost some of that authority. But coming back to the concept of trust, everybody who goes into medicine now, by and large, 99% are in it because they really love people and they want to do the right thing. It is not a financial windfall to become a primary care doctor now, okay? Newsflash. So how do we make this productive that can translate in a way for consumers? And whether that's an employer buying a plan or an individual patient is, I think, going to be a really, hopefully, positive area of growth if physicians and other healthcare providers can get on board with the idea that if we can tame these kind of ratings and reviews in a way that we agree is fair and we regulate ourselves, I think you could get buy-in. But if it's done by a third party, there are very, very few globally agreed upon metrics. I mean, maybe a few success stories are at the hospital level, you know, catheter-associated urinary tract infections, the old stuff. And they've been talking about that since I was in college. We really haven't come up with anything new that can be globally agreed upon as fair metrics. But I do have some optimism.
I'll take this from the hospital perspective, and what I worry about is taking the power away from the physicians. And I'll use transplant as an example. Highly regulated, scarce resource. But at Duke, being a quaternary research education institution, you know, you want me to push the envelope. You want our physicians to do the first partial heart transplant, which they did a couple months ago. If that's not successful and it dings my quality, I could lose my transplant program. And so where is the line of reasonableness, again, with a scarce resource, to push the envelope? Because if it's your family member, you want me to do that surgery. And so I think we walk this line of risk-taking where, you know, they're coming to me as the hospital leader saying, can I still do these types of surgeries? And there's no way I should be making that decision. And so we need to make sure that we are putting this in the hands of the people that do the work, and we can make reasonable decisions.
He may be a contemporary of yours. And I do not know him personally, there's a general surgeon at Emory Hospital named Jim Galloway. It's called the Galloway Service because he will operate on hernias that nobody else is willing to even consider. And I have seen somewhere on some insurance website like a 1-star rating from patients because it didn't work. But what's not conveyed in that data is Dr. Galloway was willing to attempt this. And the level of respect for him clinically, I don't know him personally, is so high, it's not commensurate with what is available in what's the transparency data available through an insurance website. I'm sure all of you go to your online directory, right? And it rates the doctors that are in your network. But the flip side of that is, what alternative do you have to get information? You have to get some kind of information, and if you don't have a good personal network for word-of-mouth referrals, you really rely on those quite heavily.
And quality isn't just between physician and patient. It's the entire system. So it's the implants that are used. It's all of the devices that are used and may or may not be approved because the regulatory apparatus makes it that much more difficult. An example that I am fond of giving because it is a real life example and it had real life consequences is that there's a company in California, the Star Valve Company, that created a lot of the heart valves that we have, and they were the ones that developed the Tabor procedure, which is the trans-arterial valve replacement, aortic valve replacement. So instead of opening the chest, you go up and cannulate a valve and you replace the valve. And it's done primarily for individuals who are at greater risk and not able to undergo a conventional open heart procedure. That procedure was available to 46 other countries in the developed world before it became available to United States citizens because of our approval process. So the quality of health treatment for end-stage valvular disease, I would suggest, was lower in the United States once that device was approved in other comparable countries from a quality standpoint than it was here. And so the transparency goes both ways. It's not just what the patient needs to know, it's what the society ought to know about the processes that result in the kinds of things that we are as clinicians are able to utilize.
When someone becomes a doctor, they join one of the only professions where they can make a bad decision or a mistake and end up losing everything, their house, everything they own. So they do walk a line of thinking about that. I've never met a doctor that wasn't acutely aware of the risks associated with the work that she or he does. We're all in some way involved in the provision of healthcare. So I want to take a devil's advocate position here. And what do you say to the person who challenges you and says, give me a break? You don't want quality transparency because you're afraid that if you are fully transparent about the quality, you're gonna have, it's not gonna be in your best interest. You're gonna open up in this litigation environment yourself to potentially losing some or everything that you have. So my question is, are we really embracing transparency about quality, outcomes, procedures, the whole gamut? Or is it in the best interest of those involved in healthcare to be a little opaque about what happens behind the curtain?
I hate to keep hearkening back to a time that worked maybe a little better, but there was a time when we actually policed our own profession. And the good guys knew who the good guys and gals were, and the bad guys knew that they were known by the good guys and gals. And you could police it, you could control it by licensure. Now that day has come and gone, and I understand and I appreciate that. But there ought to be a way to insert specialty society certification, approval, authorization for individuals who may need a little more training, may need a little more attention. The system that I would suggest virtually every one of us in this room trusts almost implicitly, but doesn't get blamed personally when there are accidents, is the airline system. So, and the reason that works is because pilots and others in the system know that if they report something that was a failure or a near miss, that they aren't penalized for that, that in fact they're rewarded for that and incentivized to do that. That doesn't, I would suggest that's a model for what the health system could be and the folks who are providing care could be, so that again, you align those incentives and make it so that people want to say, Dr. Smith probably didn't do exactly the right thing on that case and may need a little more assistance. And as opposed to somebody kicking Dr. Smith off the staff or saying that she can't practice there anymore or sending her elsewhere and not tell anybody what Dr. Smith did, that's a bad system for patients. And so I think that there's a better system that's out there that we ought to emulate.
Well, I'm practicing every day, and I make mistakes every day. So that is known to me and all my patients. And I tell them usually when they establish care, if you think I've made a mistake, just let me know. If I didn't ask all the questions that you think I should have asked, let me know. And so my generation of physicians and those in the future are more comfortable with the idea of total exposure. And this is not the first sort of conversation I've had where someone asks this. And I think you can extrapolate it to any industry. As the president of a company, imagine your email was on public display for everybody to see every day. Okay, you may think a little differently, but my concern is that it would slow you down to the point where you're so worried about exposure that the access issue becomes even worse. And that is, from a systems perspective, really my concern. Not so much about the patients knowing all the mistakes that we make, because most of them don't, in what I do, result in death. They may result in a delay of care. They may result in a longer treatment course, but they don't result in death. Now, a surgeon may have a very different perspective on it. So I think we can, but there's natural resistance to anybody opening themselves up to more exposure, and physicians are no exception to that rule.
I mean, I think you have to look at the flip side as well. What do we pay for more quality? So let me give an example. Times are tough. Everyone's looking at every piece of data, and so I get called in to say, you know, Mary, your ECMO length of stay is larger than almost anyone's in the country, and this was during the height of COVID. But what no one was failing to look at is that my survival on ECMO was also the highest in the country. So I'm keeping people probably 30 days longer than anyone else, but those people are walking out of the hospital. But I'm not getting paid any differently. And so it's an interesting position to be in, to be beat up for length of stay when you're actually curing people and they're walking out of the hospital. And there's no differentiation for that. There's outlier payments, et cetera, but certainly not enough to cover costs. So I think we need to look at the flip side of quality as well, not just how are we taking money away, but what are we doing when someone has excellent outcomes that, again, may cost more.
So we don't have an insurance company or payer on the stage, but they fight like crazy to not be transparent. They might be the ones that hide the most. What would happen if we provided transparent, before I ask the question, and yet they get involved in the care that's authorized for the patient? They get directly between the physician, the facility, and the patient, the caregiver, and they drive care decisions, at least as far as what they're willing to pay for and approve. So what do you think would happen if we insisted on transparency and accountability for the care decisions that payers are currently involved in?
Now you're talking, Preston. We're about an hour into it. Yeah, let's, when you're a physician or anybody who's delivering direct care, so that in OT, PT, speech and language pathology, you become the face of the medical condition. And one of the most vexing problems in delivering care is the insurance companies are essentially nameless, faceless entities, and so are large health systems. But you are sort of the punching bag for all the frustration that the patient is feeling with this big system. As a professional, you cannot share your frustration that you are equally disappointed and distressed by what is happening. And in defense of anybody who takes care of patients, imagine in whatever your profession may be now that you have 20 meetings a day, and each meeting is 20 minutes, and you've got to be on point for every meeting. So the flip side is the insurance company, zero accountability, because that choice is usually made for you by your employer if you're an employer-sponsored plan. To make that information digestible about the number of prior auth denials, the number of pre-certification denials, I hope is, and this is a regulatory, I think, area for improvement, is that should be a bipartisan, all levels of government interest, because they're the largest payer at this point, right? And even Medicare contracts with commercial plans quite heavily. So,
one of the other examples of insurance company challenges for those who practice and take care of patients is a stark one. If you look at, there was a study recently done on prior authorization and demonstrated that, and prior authorization is what offices go through, practitioners go through to make certain that the patient's insurance company is going to cover whatever it is that they're providing. And so they call the insurance company says, no, you can't do, or they send in the form, you can't do that. And then there's an appeal process, And when you go through that appeal process, the recent statistics show that 80% of the initial denials were overturned, over 80%. So that means that the company is denying 4 out of every 5, whatever it is, fill in the blank in terms of treatment, and yet ultimately deciding that 4 out of 5 of those were appropriate. Once you spent the requisite time and effort to help the insurance company understand. So we haven't talked much about solutions yet. Let me put a solution out there to that point. And that is that if we had a system, imagine a system where the patient, regardless of who was paying for their insurance coverage, whether it was Medicare, Medicaid, private sector, and employer-sponsored coverage, whatever it is, what if the patient actually owned the policy and could move that money? So that when the insurance company said to the patient, "I'm sorry, you can't get that MRI," and the patient would call and then say, "But my doctor believes I need that MRI," the insurance company then is talking to somebody who is consequential in that equation, and there's an incentive for the insurance company to satisfy that customer, that patient. And if they don't, then there's an opportunity for that patient at some point to say, "I don't trust that insurance company. I'm going to find somebody that actually I trust." Imagine a system that would allow that to occur and then change the incentives in how you get to quality medicine, more cost-effective medicine, and more responsive medicine.
To Deep's point earlier, imagine being a newly diagnosed cancer patient. Doctor says you need a PET scan to see if it's spread or where we're going, and I at the hospital can get you in tomorrow, but I have to call you back to say it's not authorized yet or we're fighting with the insurance company. They're not mad at Blue Cross or United. They're mad at the hospital that why can't you get me in and why didn't you get this done sooner? So I love that suggestion of having the patient having the ability to move where their needs are being met.
Our response to the COVID-19 pandemic was it was an impetus to try some things that for many years had not been allowed. Things like telehealth, Medicare payment for telehealth, allowing doctors to see patients across the state line where they didn't have a state license but were temporarily allowed to practice by virtue of the need. Those were solutions that we pursued. Now, interestingly, that impacted access to care greatly. People in rural areas can pick up the phone or log in, and they can be talking to a physician 24 hours a day or a provider. And yet, across the South, maternal mortality, fetal mortality, chronic illnesses like obesity, diabetes, and so forth have continued to tick up. Continue to get worse. There's more access, I think you could argue today, easier access, and it was a response to the COVID-19. For one thing, just at a real simple level, we quit putting sick people in the same room with communicable illnesses and diseases, right? Which is not a great idea, but that's what we were doing. So now we can separate those and allow care to be given. What do you see as it relates to quality? Those changes that we were able to experience during and following COVID-19. And do you see that as changing the trajectory of both cost and quality, and if so, how?
Just to marry it to the point about the portability of your health plan, I think in a healthcare utopia, with some constraints that are unique to our healthcare system here, the portability of your medical record, the portability of your insurance plan, and also to create an environment in which physicians, nurse practitioners, pharmacists, wherever can be free to practice where they feel most supported. And that is not every state in the union. There are different policies in different states, I think would be a very positive thing. What is the flip side of that? By making it a national playing field, you are also compelling states which have a lower average income and lower pay rate to compete with New York and California pricing for those physicians and other staff. So how are we going to mitigate brain drain losing people just for remote pay, which is higher. And that's not healthcare specific, but it could cause, an acute or subacute access problem. So I'm all for it. And I think that most doctors want to have freedom to practice where they would like, and that would also create incentive for our employers, the health systems, and the insurance companies to negotiate better contracts to keep people where they have a network presence.
Well, I think not only the portability of the physicians, but the portability of the location. So hospital at home during COVID was a great thing. And with the waiver, we were able to use that. I can tell you now, there's no way for the hospital to make money on a hospital at home. Where we see it is almost a cost avoidance. So I can get that patient out that may need a week more of care and get the next patient in, but it's not paying for itself yet. So how can we look at our payment models to say, yeah, I'm gonna have to send a nurse out twice a day. What's the cost of that? And yes, it's okay to provide that in the home. We struggle with this all the time with folks that may need IV antibiotics. I can't send them somewhere to get that, particularly if they've got to get it 3 times a day, and if they've got an opioid history in their background. Those are patients that I've got to keep in the hospital to provide that care. So we need to look at some different structures in terms of locations we deliver that care as well as who can see those patients.
Wasn't it amazing how rapidly we innovated under a crisis? And I think that we ought to be proud of that, that we were open to different models and different ways to allow individuals to access care. So I think there are some benefits, and I think that we ought to look long and hard about which ones ought to remain and where were we potentially compromising the care being provided. One of the challenges that we had during COVID was that the delay in treatment for many chronic diseases, because individuals said, I'm not going into the doctor's office, I don't want to go anywhere, and therefore they didn't get, you fill in the blank, checked and make certain that they were continued to be cancer-free, or that it was still in remission, or that they hadn't developed something else, or that their cardiac disease was under control. And we're seeing the results of that, some of the results of that right now, and will for a longer period of time. So there were good things in there, and there were I think harmful things, significantly harmful things. I think that telehealth, the virtual health care that we began to accept as a society, is someplace that we ought to look at seriously for continuing and continue to be paid for. If it's not paid for, then it doesn't make a whole lot of difference, because it won't be able to be utilized by many patients. So I'm not a fan of national licensure. I would be inconsistent trying to keep the decisions closer to home. If I thought that Washington would do a great job in national licensure, I just don't have that confidence. And I don't think that DC can be as responsive as the individual state, regardless of the 50 states plus the District of Columbia, in providing licenses to individuals that they believe are going to best help their population. So I think it ought to be kept at the state level, but I do believe that some cross-state lines treatment ought to be able to be utilized.
I think that's part of the interesting evolution of the entire healthcare ecosystem. In anesthesia, which is our part of the ecosystem that Premier Anesthesia works in, when COVID hit, and 50 state governors issued executive orders that no elective surgeries could go forward until further order, we saw the revenue in our business just stop. It just went off a cliff and just, straight down. Certainly more than 50%. I think it was more than 60% in about 2 weeks. Yet, what we immediately did was realize that the demand for anesthesia professionals had never been higher, because COVID was an upper respiratory illness. And anesthesiologists and nurse anesthetists are experts in maintaining airways and intubating patients and managing event. We don't usually call it event in the OR, but it is. And so we were looking for spaces in the hospitals to create negative pressure rooms, to put ventilators in, if necessary, to use the ORs to treat patients who needed ventilation. And of course, the government did step in and create some payment codes that allowed anesthesia providers to give critical access care, to work in the ICUs, to work in the emergency rooms, and that's exactly what they did. We thought we were going to have an oversupply of labor and no revenue, and the exact opposite happened. We had an undersupply of labor because we found our providers, the doctors and the nurses that work for Premier, volunteering to go into the hot zones as the waves swept across the country. And it really did bring home what people meant when they referred to them as heroes. And they put themselves directly over the face of patients who had to have surgeries, who were in trauma, who had burns, who had deliveries, who had cancer surgeries that had to go forward. So the elective surgeries paused, but that didn't stop surgeries in general. It changed the dynamic of the healthcare ecosystem. And I think in many ways that toothpaste is out of the tube. I think realizing what we can do with telehealth created a new thought process around innovation in healthcare and transparency. When we discovered in that process that, or along this path, that machine learning can help anesthesia providers who are working in a supervisory relationship, say a physician supervising a nurse anesthetist, to be able to have a flag from the computer when a patient's hemodynamics have changed, and the computer can tell the doctor, sometimes before the doctor realizes it, what path the patient is going down. Because normally when you have an adverse condition, it's a cascade of things that happen. And that way, when a doctor walks into a room and he sees the patient's blood pressure and the vitals that he's looking at or she's looking at, it means something different when you realize that the patient's been given pressors for the last 2 hours, and that blood pressure is artificially inflated, and there's another problem going on that the numbers, the discrete numbers don't tell you in the story, but the machine can. So I think there's some real advances to that, and I think it's going to really be an improvement trajectory and a fun time to be involved in healthcare. I'm going to pause right here. We have carved out a few minutes at the end of this session for Q&A. I believe it's the only session. Well, first of all, I believe it's the only session that's an hour and a half long. Sorry. And secondly, I think it's the only session where there's Q&A, so it's a unique time. And I have a colleague who has one of our microphones. So if you have a question for the panel that you'd like to ask, I would only ask that you keep it in this subject matter relating to the state of healthcare as it relates to the transparency of quality and of costs. If you've got a question in that area, please raise your hand or stand up, and we'll get a mic in your hand for the panel to address.
Hi, Michael Kedme, KCA. We do permanent placement of physicians. This is to anyone there. We're talking about transparency, but what about on getting physicals and things like that? So, in my firm, everyone's on high deductibles unless their spouses have insurance, and so you try to ask what tests and this or that, and you still can end up getting a $300 bill when you've even asked all the questions and there, and you do want to ask and know what's going on in there, and some providers are better than others at doing that, but you still get some very unpleasant surprises from our employees and from stories there. It's like you get an oil change, there, and you think you're going to pay $50, and then it's $700, and that wouldn't fly. But I think there's some things that, what are your thoughts on transparency for those types of things where, patients, educated patients do want to know and ask those questions, and want to know what kind of blood tests are going to be drawn, and well, do I really need this or that, and be able to have that, conversation with the physician as a partner.
Yeah, great question. So patient's perspective, they ask all the questions they can, and they still get surprised. We're in a new era about surprise billing. And I know that's not exactly the limit of his question, but a law was passed, went into effect January 1st of this year. They called it the No Surprise Act. I always worry about the names they put on bills. Digging down under it, the effect of what it did was give insurers, payers, all of the negotiating power. Because the only thing that a provider could do to negotiate a rate with a payer would be to go out of network and to force the insurers to the table. Now, that is not, it doesn't have any effect on the payers. So they pay more or less what they want to pay, and providers and facilities even don't have any negotiating power. Yet this is an interesting point, because I think this was what resonated from Washington when they were working on this bill, this concept that you can try your best, and due to all the confusion and all of the things behind the curtain, you still get surprised.
Well, since you mentioned physicals, I'll start. And I'm sorry, your name was? Michael. I think you are raising the point that almost every patient asks before we see them now. Can you give me a fair cost estimate about what's about to happen when I walk in that exam room? And this has become standard in most community practices. We actually, just last month, with our official wellness paperwork, there's a cover sheet that says this is exactly what's covered. And it explains to the patient that, Kevin, we wish we had time allocated during this visit to also discuss those other issues. But in the world we live in, some of the doctor's time is related to how much they have to be paid. So if what you want to address is outside the scope of these services, please expect you will get a second charge. And we started this process at our practice almost 6-7 years ago as deductibles really started taking hold in the market. And the staff, who are incredible people, by and large, women over the age of 40 who work our front desk, were very anxious about asking for $100, $200, $300 at the window, and I do not blame them. But what we have seen is that honesty with them about what's about to happen has made us one of the most trusted groups. And so I think you're going to start seeing everybody trying to do this, because we don't want you to be surprised. And going back to Preston's original point, we don't know what you're going to be charged, which is the scariest part of all of this half the time. But we really try to provide an estimate within 10%. And we think that's pretty good. So I think you bring up a great point.
The only thing more surprising than a medical bill is your Ticketmaster charge. You're trying to buy two $200 concert tickets, and all of a sudden it's $755, right? Yeah, we need to do a better job. So does Ticketmaster.
There's an interesting potential solution that's out there for certain populations, and that is putting the provider at risk financially for the entire period of care. But what has to go along with that is to absolve the provider of liability if he or she does something that not that's below the standard of care, but that within the standard of care, and you get an adverse outcome. But if the provider is actually at risk, then he or she is going to be doing exactly what they believe to be necessary to keep that patient population well and have a quality outcome. And then they benefit. You align those incentives again. They benefit when that works. So there's an opportunity there.
That's great. Another question. We've got a couple of minutes. Yep.
Thank you. Doug Gregory, and a little bit about myself. MBA from University of Illinois, registered nurse, been a hospital administrator for many years, and a fellow and on the board of GAHI. I can't figure out my own hospital bills, right? And I think this is part of the problem. We've had a lot of transparency and a lot of talk about that. But we go in for an episode of care, I get 7 different bills from all 4 of you, right? My surgeon, my anesthesia, primary care, or the doctors or hospitals, however it is. How do we simplify that for the consumer, right? Because I'm pretty educated in this space, and I just sit and wait for bills to come in until I start getting late notices, because then I know my insurance is paid, right? And I get my EOB. We've got to have a better way of doing that for the patients and simplify the care models and the payer models. And some of this I go back to the payers, which I don't think we spent much time on. But I love it, and it's a broad question, so I'd love for anybody who wants to take it. But I'd love to get people's feedback on that.
Yeah, I think, sometimes it's legally we can't provide you the same bill. So as an example, until July 1st, the physicians at Duke University Hospital were a separate for-profit entity. So we had to have separate companies, separate billing. We couldn't share charges. And so it's often very confusing. You'll get your anesthesia bill that's separate if that's a provider outside of the health system. So I think you're right. I think we need to find a better way, even with some of the regulations, or to change those regulations so that you can get one bill, or you're at least aware, look, you're going to get 4, and this is where they're coming from. I think, and I hate to say it, I'm the same way too, and I work there. To say, okay, yep, that's the second notice, I guess insurance is paid. So we do need to do a better job. In the first hospital I ever worked at, my CEO took his wife in and didn't understand his bill and got a 1.5-page response from the billing department explaining his bill, and he had framed that and put it in his office as a reminder of how unfriendly the system was for patients and how we need to change that.
And in fairness to the providers, you know, it's not good enough to know what insurance company is your payer, because, you know, there's 25 different plans.
Yep.
And so the provider doesn't always know exactly what that plan is, not to speak of your copay, your deductible, your out-of-pocket individual, your out-of-pocket for your family. I mean, it's a complicated calculation to do. I could see a time when, as a condition of participation, for example, you're required to disclose on some form that puts it all into a uniform category. But I mean, my daughter is a law student, and she's aged out of being on the employer plan under my plan. And so she went on the exchange and chose a plan this week, and she called me to ask me what I recommend. And I said, well, show me your choices. 60 different plans. She had to choose from. She put in her income, which is pretty much zero, and you know, she had to choose first between bronze, silver, or gold, and she's like, I mean, I don't know. I want to be a gold, but I doubt I can afford it. So she put silver, and was given 60 choices in plans, and many of which were on the same carriers. Blue Cross had, I think, 11. Anthem, Blue Cross Blue Shield of Alabama. So. It's a complicated structure. I do think uniformity will come from the transparency, whether by the market or by some sort of regulation. Well, one of the goals that we had for this session was to do a deep dive, because we've all been to conferences and seminars where people kind of talk in generalities about collaboration, and you walk away not getting a lot of detail, and we wanted to have a bit of a deep dive with you. We mentioned earlier the website on pricing. There's another one that you might want to look at if you're just diving into this, called fairhealth.org. It was actually born out of a lawsuit in New York State, and as part of the settlement between the Attorney General's office and the carriers, the payers, they're required now to have accessible to the public across the country, not just in New York, you to be able to put in the procedure that you're getting and get back the average charge for that procedure. Now, it's just an average, so but it's a form of benchmark that patients can do. Some of this transparency and information flow has created new problems, and that is bad information people are getting, right? So they are more informed. They're also misinformed in many ways, and they are taking ownership of their health care. I think we want them to, because we're asking them to pay more of the bill. And so to the earlier question, being able to sort out the charges and understand the fees and the charges, I think, is critical to the future state. I think AI will play a part in that. Do we have one final question we can take?
Hello, everyone. My name is Andre Ellerby. I'm with Creed Market Access Solutions. I do have a question around more so when it comes to healthcare and cost. So it's no secret that the largest cost to the U.S. healthcare system are monoclonal antibodies, right? And so they're very expensive and very well needed. Why is there such a pushback on biosimilars here in the U.S. when they've used them over in Europe, when they can provide, more access to patients who didn't have access to these therapies before, and plus they are half the cost? Can I get anybody's opinion on why there's somewhat pushback in the United States?
I know you've never heard this before. There's a political response to that, and that's the reason. I believe it's the reason. In D.C., we worked on this a lot and tried to get biosimilar access moved to the head of the line. I know, surprise, surprise, very strong lobbying effort on the other side. And it's a real challenge, but needs to happen.
there was a quote from Ronald Reagan that the most terrifying words in the English language are, "We're from the government and we're here to help." That should scare you a little bit. Thank you so much for attending this seminar. Thank you. What we haven't said is that you have touched thousands and thousands of patient lives. People have discovered illnesses that are early enough to be treated. People have received transplants. People have had their lives saved. Soldiers have been put back together by virtue of the work that you have done 24/7. And thank you for your service in that area, and thanks for participating in this panel. Thank you.